My name is Alex Krist. I'm a family physician and the vice chair of the U.S. Preventive Services Task Force. For 20 years, I've seen patients, taught residents, and done research at Fairfax Family Practice and Virginia Commonwealth University. The U.S. Preventive Services Task Force is a group of independent volunteer experts in evidence-based medicine and preventive medicine. We work to improve the health of all Americans by making evidence-based recommendations about prevention. Prostate cancer is one of the more common cancers to affect men. Based on a review of the evidence, what we're recommending in two parts is that men between the ages of 55 and 69 who are considering screening talk with their clinician, understand the benefits, understand the harms, weigh their values, and make a decision with their clinician. And we're recommending that patients 70 years of age and older not routinely get screened for prostate cancer. The screening test for prostate cancer is a blood test called a PSA blood test, or prostate-specific antigen. This can be elevated for men who have prostate cancer, but it can also be elevated for many other reasons. What the science tells us is that among men who choose to be screened, about 1 in 1,000 won't die from prostate cancer, and about 3 in 1,000 won't get metastatic prostate cancer. However, we also know from the same science that there are harms from prostate cancer screening. And while a few men will have benefits from screening, many men will have harms from screening. The harms include 3 things. The first harm is false positives. So a false positive means that a man has a high PSA test, but they don't have prostate cancer. That might lead to a biopsy, which can have some complications. The second harm that we think about is what we call overdiagnosis. And prostate cancer is a unique cancer. It grows very slowly. Most men who get it will never know they have it. They'll never have signs, they'll never have symptoms, and they'll only know that they have prostate cancer by getting screened for prostate cancer. We're not very good at figuring out which cancers are overdiagnosed and which ones will progress and affect a man in his life. So these men might get treated, and it might be a treatment that they don't really need. The third harm we think about is the harm from treatments, like surgery and radiation. And that can lead to urinary incontinence and erectile dysfunction. And that can really interfere with a man's quality of life. Now, one of the problems that we have with the science is thinking about high-risk men. So men who are African American or men who have a family history of prostate cancer, does screening help them any more than an average risk man? And we also don't know, do they have greater harms from the whole screening process? We need more studies to know what's right for high-risk men. And for high-risk men, we're saying that our current recommendations apply. The task force recognizes that the decision about prostate cancer screening is a complex and a personal decision. We encourage patients to talk with their doctor and make a decision together about what's right for them. For more information, visit USPreventiveServicesTaskForce.org.